So let's just go for the calcium metabolism. How is the calcium level controlled in the body? Calcium metabolism through the various hormones. So the important thing is one is parathormone. This is thyroid gland. It has got parathyroid superior, inferior. Then this secretes PTH, P parathormone, PTH parathormone. Then another thyroid cells have got C cells which secretes calcitonin, parathormone. These are two opposite. Then there is skin sun rays, they convert calciferol to cholecalciferol, vitamin cholecalciferol. Then it is converted into 25 hydroxy cholecalciferol. It is cholecalciferol and it is converted to 125 hydroxy cholecalciferol. So first skin, then skin it is converted to 25 hydroxy cholecalciferol, then 25 is converted to 125. Skin it goes into liver. In liver it is, this is first step is in skin, second step is in liver, and third step is in kidneys. So this is kidneys. 125 hydroxycholecalciferol is formed in the kidney, that is vitamin D. Now this is also called as vitamin D. So calcium metabolism is controlled. The highest maximum the level the calcium is present in the bones, maximum in bones. So this is a bone. He has a reservoir. The second part where calcium is taken, it is a oral from stomach, and third is where the calcium can be in the kidneys. So this is kidneys. So now parathormone, there is level of calcium in the blood. What is the normal level of calcium in the blood? It is present, calcium is present in the blood, protein bound with albumin and free calcium. So now what happens, it is corrected calcium. Whenever there is hypoalbuminemia, calcium plus albumin, that is actually corrected. If albumin level goes down, then you will get less calcium in the serum. That's why ideal calcium has to be corrected calcium. That is called as corrected calcium, depending upon the albumin level in the body. So whenever calcium level goes down in the blood, that stimulates parathormone. So this calcium, whenever the level goes down, it stimulates parathormone, and parathormone acts on the bones to release calcium into the blood. One thing. Then parathormone acts on the kidneys distal convoluted tubule to reabsorb the calcium which has already gone into the descending loop. So it increases reabsorption. Then parathormone acts on stomach along with vitamin D. Both these act to increase absorption. All these three, PTH, vitamin D, they cause increased calcium level. So parathormone has got an effect of within 10 minutes. It's half-life is 10 minutes. So in GIT, increases calcium and phosphorus along with this through vitamin D. So here phosphate is also absorbed. While in bone, it causes reabsorption by stimulating osteoblast. Initially, osteoblast are stimulated. So the calcium is increased. Whenever calcium level goes down into the blood, it stimulates parathormone to act on. The parathormone acts immediately on. Parathormone is released. It acts on bones. It acts on kidneys. It acts on GIT to release, means from bones calcium is released into the blood. From on kidneys, distal convoluted tubule, it absorbs the calcium, it increases the blood. On stomach, parathormone acts on stomach, it increases absorption, dietary calcium. So all this, they suddenly increase the calcium level. So calcium level is increases. That is now calcium is present in, calcium is bound in. This is one thing. And vitamin D, as it is formed. So any deficiency in vitamin D, parathormone may lead to hypocalcemia. So hypoparathyroidism. So there are two situations where parathormone, if it is increased because of adenoma, so there are two things. So what happens? Bone is the basic storage house. Second is dietary calcium. Third is calcium which is going out of the kidneys. Now what happens? What are the conditions that cause increased calcium level? So hypercalcemia. This may occur most commonly in hyperparathyroidism. Hyperparathyroidism, increased parathormone level. This basically in primary and tertiary. In secondary, it will be normal calcium. Second is, it can be in sarcoidosis or calcium vitamin D supplementation excess. Increase calcium plus vitamin D, milk alkali syndrome, and most common is metastatic cancers like CA breast, where you get hypercalcemia, increased calcium. What happens because of increasing calcium? So now calcium level has to be corrected. In what way? If calcium is more than 2.6 millimoles per liter, this is elevated adjusted calcium. So adjusted or corrected calcium, how it is that? It is adjusted means serum calcium plus 0.8 into 4 minus serum albumin. So you have to multiply with this factor 0.8 into 4 minus serum albumin, because if there is hypoalbuminemia, there will be decrease, actually that is corrected calcium. So this can be in any diseases, and this hypercalcemia is hyperparathyroidism that leads to called as bones, stones, groans, and psychic moans. So psychic symptoms, abdominal pains, kidney stones, pain, bone pains. So these are the clinical picture. And what you see on ECG, because calcium being a basic ion for excitation, that leads to QT interval shortening, because there is a lot of excitation. That's why QT interval shortening. Now hypercalcemia has occurred. How you are going to treat it? Immediately you have to measure it and see. So what you give? IV fluids. IV fluids is the first line. Basically 0.9 normal saline is the best fluid in first line of treatment. Then second, you go for bisphosphonates. Second is bisphosphonates. These may be pamidronate, zoledronate. Third is calcitonin. Calcitonin is opposite action. You can see calcitonin is secreted by parafollicular C cells. This is calcitonin. It has totally opposite. It deposits the calcium back into the bones. It prevents calcium to be absorbed from the kidneys. It prevents calcium to be absorbed. It has got totally opposition and it lowers the blood calcium level. It helps to decrease blood calcium. So hypercalcemia, it has quickest action. Then you have to give in sarcoidosis and all that. You have to give prednisolone and all that. Then sodium bicarbonate can all be given. So this is about increased calcium level. Now, if you get opposite scenario, what happens in that when suppose you have got hypoparathyroidism, less parathyroid, or you have got less vitamin D. So if suppose you are doing when will hypoparathyroidism occur? Thyroid surgery is done, major thyroid surgery is done. You have removed the thyroid along with accidentally parathyroid has been removed. So that may lead to in decreased calcium, that is hypoparathyroidism, because parathyroids are accidentally removed or necrose. In another condition, pancreatitis, it damages pancreas, that leads to hypocalcemia. Then along with this magnesium deficiency, it can be associated with magnesium deficiency, respiratory alkalosis. So all these conditions cause decreased calcium. Whenever calcium is decreased, means excitatory, it is lost. So muscle twitchings are there. What is there? The latent tetany, that leads to latent tetany. It is measured by Chautek's sign and Troje's sign. Then perioral numbness, or you get muscle cramps. Here QT interval is prolonged because excitability is reduced. So QT interval is prolonged. Treatment is 10 10 10 10. You have to give this 10 ml 10% calcium gluconate in 10 minutes. So this was about the way PTH, calcitonin, and vitamin D. Vitamin D deposits the calcium into the bone mineralization. It helps, and also it increases absorption phosphorus as well as calcium. Parathormone is a polypeptide. It has got a half-life of only 10 minutes. Vitamin D, because of ultraviolet rays, it is stimulated, cholecalciferol is stimulated, and then cholecalciferol is hydroxylated in liver by about 25 hydroxylase. Then from there in kidneys 125 hydroxylase. So hyperparathyroidism may be of three different types. PTH increase, primary, secondary, and tertiary. So primary basically because of adenoma, means parathyroid itself, and this is hyperplasia because of stimulation. Hyperplasia, cells are stimulated, this is hyperplasia. So secondary occurs most of the time when there is associated chronic kidney patient. So what will happen? PTH will increase. This is PTH. Parathormone, definitely it is going to be high in all the three. What about calcium and what about phosphate? These are the two. Calcium and phosphate has got the opposite actions. So when parathormone is increased in all the three, okay, parathormone. Now what happens in adenoma? Calcium occurs, calcium also increases. In secondary, calcium may be normal. In tertiary, it increases. While phosphate, when calcium increases, phosphate goes down. Here phosphate goes down. Here it can be normal. So normal calcium, increased parathormone will be seen in chronic patient, secondary hyperparathyroidism. This is secondary. Otherwise, in all the other things, adenoma, calcium is increased, parathormone increase. In tertiary, calcium is increased, parathormone is increased, and phosphate is less. So this is about parathyroidism, parathyroid.